Your patient with cirrhosis is confused and pulling at their IV. The ammonia level comes back elevated. But what does that really mean? Today, we're breaking down ammonia levels, how they tie into liver function, and the lab values every nurse needs to understand in liver disease. So, let's start with ammonia basics. Think of the liver as a sophisticated recycling plant. Normally, it takes ammonia, a toxic byproduct of protein breakdown in the gut, and converts it into a harmless substance called urea. The kidneys then easily filter this urea out of the body. Simple enough, right? But what happens when the liver is failing, like in cirrhosis or an acute liver injury? That recycling plant shuts down. Ammonia starts to build up in the bloodstream because it can't be converted. When this toxic ammonia crosses the blood-brain barrier, it leads to a condition called hepatic encephalopathy. This is why your patient becomes confused, lethargic, and might even develop that classic flapping tremor, known as asterixis. Here's a crucial clinical pearl. The ammonia level doesn't always match how out of it the patient looks. You might see a sky-high number in a patient who is only slightly confused, or a slightly elevated level in someone who is completely altered. Always treat the patient, not just the number. Now let's look at the bigger lab picture beyond just ammonia. To truly understand liver disease, you need to know these key labs. First, AST and ALT. These are liver enzymes. When you see them elevated, think inflammation or injury. It's like a smoke alarm telling you there's a fire in the liver cells. But these labs don't tell you how well the liver is actually working. For that, we look at function labs. First is bilirubin. When the liver can't process old red blood cells, bilirubin builds up, causing that telltale yellowing of the skin and eyes or jaundice. Next is albumin. This is the main protein made by the liver. When the liver is failing, albumin levels drop, which is why you see things like edema and ascites. Finally, there's the INR, or International Normalized Ratio. This measures clotting time. Since the liver makes most of our clotting factors, a rising INR in a patient who is on anticoagulants is a major red flag for severe liver dysfunction. Here's another pearl for you. If you see the INR climbing in your cirrhotic patient, that's the liver failure talking, not a medication error. So how do we put all these numbers together? That's where the MELD score comes in. MELD stands for Model for End-Stage Liver Disease. It's a powerful scoring system that uses bilirubin, INR, creatinine, and sodium to predict a patient's 3-month survival risk. A higher MELD score means a higher risk of mortality. As a nurse, if you notice these specific labs are all trending up together, you should be recognizing that you have a very sick liver patient, even before a doctor calculates the MELD score. And here's why this matters so much. The MELD score is the primary tool used to prioritize patients on the liver transplant list. It's literally why they are listed for transplant. Okay, let's bring this back to ammonia in daily practice and how we treat it. Remember, hepatic encephalopathy is a clinical diagnosis. Don't hang your hat on the ammonia number alone. Your assessment is what truly matters. The go-to treatment is lactulose, sometimes with an antibiotic called rifaximin. So how fast do these medications work? Lactulose can start improving a patient's mental status within hours, usually around 6 to 12 hours, but only if it's working and the patient is having bowel movements. The goal is 2 to 3 soft stools a day. The ammonia lab value itself might take longer to come down, typically 12 to 24 hours, but sometimes up to 2 days. Rifaximin works a bit slower, taking about 24 to 48 hours to make an impact, which is why it's often used as an add-on therapy rather than a standalone treatment. And here's my final and perhaps most important clinical pearl. A patient's mental status often improves before the lab number changes. That's why your nursing documentation is so critical. You need to be charting their orientation, alertness, and their response to therapy, not just sitting back and waiting for the ammonia to drop. So to recap, ammonia is a marker of encephalopathy, but it's an imperfect one. AST and ALT signal liver injury. Bilirubin, albumin, and INR tell you about liver function. The MELD score predicts survival. And when it comes to treatment, the patient's symptoms often get better before the labs do. Remember, treat the patient, not the number. Your labs guide you, but your clinical assessment drives the care. Thank you for supporting my channel. Have you ever cared for a patient with hepatic encephalopathy? What tipped you off first, the labs or their behavior? Share your story in the comments below. And be sure to subscribe so you don't miss our next video, where we're tackling why lactic acid lies in liver patients. Thanks for watching.